Thanks to organizing committee for this very appreciated invitation, and I'm really honored to give a lecture on state of the art lecture on antiviral therapy. So antiviral treatment for hepatitis B, these are my financial disclosures. This is the outline of my presentation. So rapidly, the natural history, very rapidly, interferon monotherapy or oral antiviral therapy monotherapy. As the next speaker will cover the issue of combination, efficacy, safety, histological data, decompensation, portal hypertension. I will not cover the issue of liver cancer because Harry Chan later on in the afternoon will cover this issue. And then, of course, when to start, how to start, and when to stop, mainly oral antiviral therapy. So, I mean, everybody knows the global impact of hepatitis B, approximately 400 million of individuals being infected, 75% living in Asian Pacific region, with quite a large number of patients developing liver cancer and cirrhosis. In terms of clinical picture or clinical scenario, we have three specific situations. One situation is the situation of inactive carrier state. It has been estimated that probably 2/3 of the infected people are really inactive carriers with very good prognosis, almost no risk of reactivation, very limited risk of complications, no indication to therapy. The rest of the infected patients are either with chronic hepatitis B without cirrhosis or with cirrhosis with or without complications. And of course, my topic today will cover the antiviral management of these two categories. And of course, the aim is to prevent, improve survival, by preventing complications. So whenever we think about chronic hepatitis without cirrhosis, we have to stop progression to cirrhosis, but also remember, try to stop progression to liver cancer. And whenever we start antiviral therapy in cirrhotics, we have to prevent, again, cancer and end-stage liver disease. And all the guidelines are in line on the endpoint of antiviral therapy, which would be really suppress viral replication. Do whatever you want, use any strategy you want, but please stop viral replication, because in this way, we are expecting, we are estimating that we will reduce all the complications, most of the complications. And how can we stop viral replication? As you know, there are two different strategies. One is the short-term interferon therapy. The second is the long-term oral antiviral therapy, long-term suppressive strategy. Both strategies have advantages and disadvantages. And of course, interferon is a cytokine, some side effects, is not really working in all patients, unfortunately. And the end point is really the immunocontrol. And then the immune system will do the job, will finish the job by reducing S antigen levels up to a level that a full seroconversion is achieved. If you cannot use interferon, it's not working interferon, you go for a sort of second-line strategy, oral antiviral therapy, lifelong, with the specific aim of keeping viremia suppressed with HBV DNA below 10, 15, or 20 units. But the most important difference is really the mechanism of action. If you start oral antiviral therapy, you see you are able to suppress only viral replication with almost no change of cccDNA activity or amount, basically no changes the subgenomic RNAs, which means viral production. So you are very effective DNA suppression, but basically no changes at the antigen production. If you use interferon, you are working at different levels. You are reducing direct cccDNA. At the same time, you're stopping, reducing replication, and also affecting the subgenomic RNAs. So at the end, you are able to reduce both DNA and antigens, and also reduce cccDNA. So from the biological point of view, of course, interferon would be the ideal oral, the ideal antiviral approach. Let's start briefly to review what is possible to achieve with interferon. First of all, the aim of interferon is not PCR negativity. The aim of interferon is to achieve an immunocontrol, which is basically inactive carrier states, by using the immunomodulatory and antiviral activity interferon. The problem with interferon is that we treat 100 patients for 1 year, and only 30% of the patients, approximately, both the antigen positive and negative, will achieve the sustained immunocontrol. The good news is that 50% of these responders will clear S antigen over time, and that responders will have a decreased risk of cirrhosis and maybe, there is a lot of discussion, a reduced risk of liver cancer. So he's working very well, but unfortunately in a very limited number of patients, a subset of patients only. So during the years, there's been several studies trying to define the predictors of response to interferon. On the left-hand side, for e antigen positive, most of the work has been done on e antigen positive patient, and on the right-hand side, a few data on the antigen negative population. However, although there's been several studies, these predictors have not become very popular, just because some of the variables tend to fluctuate over time, like DNA, transaminase. Others, like genotype, is not routinely measured. Others, like wild type versus pre-core mutants, is not a routine test available everywhere. And the most important reason why they are not so popular is because the negative predictive value or the positive predictive value of these variables are not very good to be used in individual patients. More recently, there's been some studies on other biomarkers like IP10, on genomics like IL-28B and other markers, but so far there is not really strong evidence that you really should look for these genomic studies. However, 2 large GWAS studies are underway. Within 1 year, we might have the first results. Well, if you cannot predict before therapy, an alternative strategy would be to predict during therapy or to monitor S antigen quantification during therapy and decide whether to continue or not. Why are we using S antigen quantification? First of all, because we have a good, easy, simple, a very effective method to measure S antigen quantification in a quantitative way. Second, because S antigen is reflecting the functional activity, we think probably, of cccDNA, which is the most important endpoint for antiviral therapy in general, but specifically with interferon. So to make a long story very short, the most important way we use S antigen quantification is by developing a response-guided therapy, mainly by defining early stopping rules. There's a list of stopping rules on the left-hand side for the antigen-positive patient at week 12, at week 24. On the right-hand side at week 12, so very early for the antigen-negative, mainly genotype D. These stopping rules are very effective, and the reason is because of the negative predictive value is very high, almost 100%, which means you can use these rules in each individual case in your liver clinics, and basically what you should do is stop antiviral therapy with PEG interferon in the 20-30% of the patients, fulfilling these stopping rules at week 12 or 24. And of course, there are many other studies trying to define other stopping rules at week 24 and at week 48, but these studies, these new rules have not been confirmed and validated yet. So I think we have to be careful before using these new rules in clinical practice. So the alternative is oral antiviral therapy. We classify in hepatitis B oral antivirals by the risk of resistance as a monotherapy. On the left side, the first generation lamivudine, in the middle, the second generation adefovir ethelvubidine, on the right-hand side, the third generation entecavir and tenofovir. Basically, this separation or differentiation is very important because you see there are some countries where entecavir and tenofovir are available, and I'll show you the data of this treatment of these results. But there are other countries where only lamivudine is available, maybe only adefovir and lamivudine are available. So there are other countries where there are still major challenges in the management of hepatitis B. Most of my presentation will be dedicated to entecavir tenofovir as a model of what you can achieve by using high genetic, high potent drugs. But then I will also make a comment on for those countries where entecavir tenofovir either are not available or are not fully reimbursed. Well, let's take entecavir monotherapy naive population. These are 6 different cohort studies coming from Europe, Southern Europe, Northern Europe, Hong Kong, Thailand, China, Japan. And here, these are the virological suppression rate as a monotherapy in naive population over 5 years. And you clearly see the message is very clear, between 95 to 99, 100%. So from the clinical point of view, I would say almost the job is done. 1 pill every day, 5 years, in real life. This is not registration trials. Everyday patients, very, very effective because the resistance rate is almost 0, it's probably 1% with entecavir monotherapy. And this is independently of the patients that you see e antigen positive or negative, with or without cirrhosis, with one genotype or the other one. So very easy job for clinicians, very simple to stop viremia. The same is true for tenofovir monotherapy, 99% suppression of viremia after 7 years in the registration trial for the e antigen negative patients, and 99% for e antigen positive, and the same was true at year 6, at year 5, at year 4. Again, very easy job for us with no resistance, no case of tenofovir resistance so far ever described in hepatitis B. And if you move from registration trials to real-life studies with tenofovir, we have a 3-4 years experience, mainly from Europe, once again, from 95% to 100% suppression in real-life, everyday patients, given that probably compliance is not 100%, probably less than 80%. Despite everything, these are the rates that we achieve as a monotherapy. Again, no case of resistance. Once again, virologic suppression, if tenofovir and entecavir are available and fully reimbursed, can be achieved virtually in almost everyone attending the liver clinics. What's about resistance? Of course, if tenofovir is available in your country, in your center, like in Canada, US, Europe, and other countries, the job is very easy once again. If you take just one study, a randomized control study in lamivudine-resistant patients, randomized to tenofovir monotherapy or Truvada, basically tenofovir monotherapy provides 96% suppression over 2 years. Job done. Resistance is not a major problem if tenofovir is available. If you take another even more complicated disease or resistant like adafovir resistance, and then again you randomize patient to tenofovir monotherapy on the left or tenofovir plus entecavir, what we call a sort of super combo. Basically, you don't need a super combo. Tenofovir monotherapy, it's enough, 60% response, and this is less than 1 year study. And if you go to multi-drug resistant patients, for example, in Europe, this is a study on super combo, tenofovir and entecavir, but now there are some data that even tenofovir monotherapy could work very well in these resistant patients. This is just really to make a point that if tenofovir is available or if early add-on adafovir can be done, then really lamivudine resistance, adafovir resistant, multi-drug resistant is not a clinical issue anymore. I think in those countries using tenofovir, I think the last time we saw a resistant patient was probably 10 years ago. And we did not see one more clinical resistant in the last 10 years. However, remember that in many countries, these drugs are not available. Many countries are using only adafovir. They cannot do early add-on because they do not monitor for DNA. They cannot even use a combination. They were forced to use a sequential monotherapies. In these countries, the management of resistance is still a major issue. China, for example. Well, if you stop viral replication, what's going to happen at the liver? Normally, we don't do a liver biopsy, but again, this is a proof of concept. If you take the entecavir study, a 5 or 6 year study, entecavir monotherapy, all were responders. All responders, 57 patients. You look at histology at baseline, at year 1, at year 6, so 3 liver biopsies. On the top panel, unique inflammation. The message is very clear. As expected, Since we are normalizing ALT levels, we also have basically no more inflammation in the liver. It was expected. But what about fibrosis? In the lower panel, you see 80% of the patients did not have fibrosis anymore in the last liver biopsy. Even some of the patients had cirrhosis at baseline and no more cirrhosis at the end of 6-year treatment. But cirrhotics were very few in this study. The most important study for cirrhosis is this one with tenofovir monotherapy. Almost 100 patients had a cirrhosis at baseline. They received a baseline biopsy, a biopsy after 5 years. The liver biopsies were compared, and you see that 74% of the patients had cirrhosis reverted during 5 years treatment. So we are thinking about reversion of fibrosis, reversion of cirrhosis at histological level. So I would think something that was just unbelievable, unpredictable a few years ago, and now is almost a routine achievement in clinical practice. Of course, not everybody achieved a reversion of cirrhosis. 24% of cirrhotics, despite full suppression of viremia, still had cirrhosis after 5 years. Why? Well, they had another liver disease. They had hepatitis B and another cause of liver disease, NASH, obesity, diabetes. So the message is that you must achieve undetectable DNA to cover for the hepatitis B problem, but you also need normal transaminase to avoid that because of another cause of liver disease, despite full suppression of viremia, cirrhosis will remain in that liver. Well, I showed you the data on efficacy, on histology, and then we move to the clinical endpoints. I will not speak about liver cancer because Henry Chan will speak, but what about decompensation? There are several studies, again, entecavir tenofovir as a model, because with this drug, you can treat everyone coming in your liver clinics independently of any baseline feature, and you will be able to achieve 99% suppression of viremia. If you treat patients with compensated cirrhosis with entecavir or tenofovir for 5 years, not one single patient will develop clinical decompensation over 5 years. Not one single case will be hospitalized, which means these drugs have a major impact of the natural history of hepatitis B in our patients. That's the reason why all the guidelines are suggested that all cirrhotics should be treated with oral antivirals. And even portal hypertension could be changed and improved. And that's probably the most important information confirming the reversion of fibrosis at histology, because if you look at these cirrhotics being followed with more than 500 endoscopies looking for esophageal varices over a 12 years period, you see that 83% of those with F1 varices at baseline did not have esophageal varices anymore during follow-up. And among those without esophageal varices, most did not even develop esophageal varices. This is a major point. We are changing the portal hypertension, which means probably we have to change the recall policies for upper GI endoscopies in our cirrhotics during antiviral therapy. And of course, when to stop oral antiviral therapy. I think the European guidelines are very clear. I would suggest you to stick with these guidelines in terms of clinical practice. The best stopping rule, even for cirrhotics, is S-antigen loss and S-antigen seroconversion. Not many data available, but all are concordant, all in the same direction. Even in cirrhotics, if you achieve S-antigen loss, anti-S above 100 or 200, you can stop safely antiviral therapy without any major problem. Of course, you have to monitor off therapy, but we are not expecting any major problem. There is another possible rule, stopping rule for the antigen-positive patients, which is very popular in Far East, and e-antigen seroconversion plus undetectable DNA consolidation for at least 1 year, maybe more than 1 year. Unfortunately, if you follow this rule, 50% of your patients will have a relapse. You can consider sort of good news or bad news. We tend not to use this stopping rule and go for S-antigen loss and seroconversion. The problem is that the probability to achieve S antigen loss during oral antiviral therapy, because of the mechanism I told you, is very limited, both for E antigen positive, which is approximately 10% a year 5, and even more so for E antigen negative patients, which is only 1% after 7 years of antiviral therapy, which means that for most of our patients, both E antigen positive but mainly antigen negative, oral antiviral therapy will be lifelong, or probably long-term, maybe lifelong in some of the patients. So this is probably the only problem that today we face when we treat our patients with oral antiviral therapy. When to start, when to stop, and a lifelong therapy. Then the point is when to start and how to start. Well, here there are two different categories. The first category is patient with cirrhosis, including histological cirrhosis, compensated cirrhotics, and decompensated liver disease. European guidelines are indicating only two variables to start antiviral therapy: S antigen level, S antigen positivity at any level, and DNA positivity at any level, independently of transaminase, E antigen status, or any other variable. So very strong, very proactive antiviral treatment, and the message is clear. If you start early, you can improve very much the natural history of these patients. Most of the patients will be on oral antiviral therapy. There is some room for PEG interferon for patients with histological diagnosis of cirrhosis. Remember that histological diagnosis is, to make this diagnosis, you need histology. Once again, FibroScan will not be very useful to identify these patients. And of course, if you use PEG interferon, be aware to avoid reactivations which could be possible during PEG interferon. The second category is characterized by patients without cirrhosis. Here you need 4 different variables before you can start antiviral therapy, generally speaking. S antigen positivity, DNA above 2,000 units, abnormal transaminase, and some evidence of liver disease. Of course, we treat everyone with a significant fibrosis, either PEG or antiviral therapy. We treat almost everyone with moderate fibrosis. We tend not to treat or eventually use PEG only for those with mild to no fibrosis, which does not mean never being treated. But we don't treat today. Maybe within 6 months, within 1 year, for a few years, we will have many new antiviral strategies, maybe more effective than today. Well, so in summary, if you live in a country or work in a country, or for all those countries where entecavir and tenofovir are available, as for naive patients and for resistant patients, and they are reimbursed, I think our job as clinicians has become very, very easy. Viral suppression can be achieved in more than 95% of the patients, either naive or resistant, entecavir for naive only, and tenofovir for both naive and resistant patients. Again, without any difference according to the baseline features of these patients. You can also achieve E antigen seroconversion, 40 to 50% at year 5, which means if you really want to try to stop, you could try to use in selected patients the stopping rule. But the best stopping rules, as I told you, S antigen clearance generally is a rare event, 1%, 2-3% over 5-7 years, but there is a selected group of people, of patients, E antigen positive, genotype A, short duration infection. They can reach even 10-20% of S antigen loss by oral antiviral therapy over 5-7 years. So oral antiviral therapy is not long-term always. Of course, 80%, 85% of the patients will achieve normal transaminase, not 100%, because many of our patients have NASH, obesity, other causes of liver disease. So you have to look after these other causes. No major safety issues for entecavir tenofovir so far. And from the clinical point of view, a complete change of the natural history with prevention of decompensation, improvement of portal hypertension, and liver cancer. Harry Chan will give you some data on liver cancer. And of course, extended survival. So The only unmet medical needs for countries where entecavir tenofovir are available and fully reimbursed are really liver cancer, and Harry Chan will tell you that we cannot prevent liver cancer. Maybe we can reduce in specific situations, and when to stop oral antiviral therapy. And all the studies now, all the new studies Harry Janssen will speak about are really looking at a way to stop antiviral therapy within a few years instead of few decades. And in terms of general perspective, we are doing very well in terms of full suppression of viremia. So the only problem is really identify HBsAg carriers and refer to S antigen positive carriers to the centers and treat these carriers. But if you live or you work in a country or where entecavir tenofovir are not available, or they are not fully reimbursed, or in a country where DNA monitoring is not available, is not easily available, or is not fully reimbursed, then the treatment options are very, very limited. Only lamivudine monotherapy, maybe plus adefovir as a sequential combination, or a de novo combination, or adefovir as a rescue, or telvibudine instead of lamivudine. So very limited first and second generation options. Well, in these countries, China, and not only China, the clinical scenario is still challenging today in 2014 because of the high rates of partial virological response on lamivudine, on adefovir, on telvibudine, and because of the partial virological response, then you develop a high rate of drug resistance. And since you don't have tenofovir, maybe do not have easy access to DNA monitoring, this will lead to high rates of multiple drug resistance strains. And this is not only a virological issue. This is a clinical issue with high rates of ALT flares, high rates of decompensation, high rates of liver cancer. And on the top of this, we start to see in those countries a safety issue because of the long-term use of adefovir in these countries where renal monitoring is very, very limited. And remember that most of the patients with chronic hepatitis B are being treated now in these countries where entecavir and or tenofovir are not available. So in these countries, the situation is completely different. The unmet medical need is just to stop viral replication. The situation we were 10 years ago in Western countries now has been faced in some Asian countries. In China, for example, now they are struggling just to control viral replication, which is for us now a problem, which is not a major problem anymore. In terms of global perspective, of course, remember that this challenging clinical scenario is typical of the high endemic countries. So this is a major problem. Thank you very much for your attention.